All right, good afternoon, everybody.
Good afternoon, everybody. My name is James Leckie. I'm the college coordinator at the American College of Radiation Oncology. Presenting with us today is Dr. Jerry Jaboin, who is the Vice Chair for Clinical Affairs at the Oregon Health and Science University. He specializes in central nervous system, pediatric, and gynecological cancers and graduated from Howard University. He went through residency training at Vanderbilt University, and he's been a member of ACRO since 2013. Aside from this training webinar today, he also is a faculty advisor for the resident committee of the college. And with that, I will go ahead and pass it over to him. If any of you have questions, you can go ahead and submit your questions in the chat section. Just switch it to send questions to staff, and we'll open up the panel for questions in the last 15 minutes of the webinar. And with that, thank you everyone for joining us, and take it away, Dr. Jaboin.
Thank you so much for the introduction, James. So today's topic is going to be business development and leadership in radiation oncology, and primarily I do want to focus on the leadership aspect of that because I think everything does fall under that. So when we talk about leadership, and bear with me as we do this historical perspective, when I thought of great leaders starting in education, it was always the philosophical leaders, Socrates, Plato, Aristotle, individuals of that ilk who shaped major changes in the way we view education, philosophy, ethics. But, you know, as we all know, the other greats that stand out are our military leaders, also influenced by those same leaders in thought, and our political leaders. But the truth is, leadership is kind of an undefined quality, only defined by the ability to be able to encourage, motivate individuals to do the next thing, and also to be disruptive effectively in changing the status quo. So, you know, here I've listed a panel of leaders that some of us would all agree would be leaders and maybe even heroic, and others may be controversial, but they all held an aspect of being able to lead and convince of their doctrine and dogma. So in medicine, when we think of leadership, it's a little bit different, right? Outside of Hippocrates, who was, again, more philosophically and ethically based, setting the groundwork for what it means to be a physician, a lot of our leaders have either been leaders in terms of creating a new style of providing medical care, like Florence Nightingale or Joseph Lister, or a new creation ideas in philosophies that underpin a whole movement within medicine, like Sigmund Freud, Marie Curie, and Röntgen, and Jonas Salk. And most of, I'd say, the mid-century to modern leaders, at least from an academic context, have all been, you know, scientists and innovators. But now we're kind of at a tipping point. So here I have Ben Carson, Deepak Chopra, Mehmet Oz, Sanjay Gupta, all physicians, all MDs who trained and completed residency in this country. But they have a different symbol now, right? These are leaders by virtue of visibility. And you know, in their own right, they have created different kind of movements and have different impact. But the question is, how do we take our next steps as radiation oncologists trying to make a stamp and have an impact and feel self-fulfilled? So here I've listed some modern leaders. Now, this list is not exhaustive. I just want to point them out for different reasons. Francis Collins, the current NIH head, he was head of the NHGRI and pioneered the Human Genome Project. A disruptive thinker at the time when he was working on the Genome Project, because he was really able to bridge a lot of institutions and smaller groups to focus on, you know, basically accelerating the pace of genomic mapping such that it wasn't going to become a privatized genetic blueprint, right? So that at the time he was really facing a threat from Celera Genomics and Craig Ventnor that they would do this project, but by doing so kind of render the academic workforce less important. But his leadership is visionary not in the techniques that were applied so much as the ability to pull people together to work towards a common unified goal within academics. Robert Wachter, who is a person I think that all of us should become more familiar with. He's probably one of the most visible leaders in terms of understanding where the field of medicine is going. And he authored a book called The Digital Doctor. And I think the crux of the book was one illustration he had basically received from a patient of what he appeared to the patient to be as a good doctor. And basically this little girl had colored a picture of him in the room with laughing parents, laughing daughter on the table, and the doctor was facing the computer screen typing. And for him, that was difficult because in his text of what he would be considered as a physician would be someone who's engaged with the stethoscope around their neck, with their leaning forward, engaged with the patient. And we are in a new age. We're in an age of documentation and technology. And not only should we view ourselves differently, we are already being viewed differently by our patients. The other goal of the book was to make people understand that, that this is not all bad, and that we can harness technology to improve care, reduce errors, and I guess reduce the need for certain kind of doctors, which is a bit scary concept. But he spoke about the destruction of the field of radiology, and this was tongue-in-cheek in a way. But I myself remember starting off medical school rounds in radiology. So, back before PACS system was implemented, the center and the heart of the hospital was in the radiology room. So to put that in context, surgeons, primary care doctors, whatever rounding you did began with you first reviewing the images under the tutelage of some esteemed radiologist, where they were providing advice and in context for you to help with your clinical scenario. Shortly after the PACS system was implemented, even for where I was within that 1 to 2 year period, everything just changed significantly. Radiologists moved to the back of the hospital, more difficult to find. Their active role and participation in the diagnosis and care of patients was limited because this technology was disruptive enough for people to actually get their own preliminary reads or not exactly have to meet with the radiologist. So tongue-in-cheek, Paul Chang, who he refers to in his book, is a professor at University of Chicago, was criticized by his dad for destroying the field because he destroyed that doctor of doctors approach that radiologists had begun. So Robert Wachter has been traveling the country, traveling the world, discussing this digital age and the physician's role in it, and the role of automation and the inevitable role of automation in the process of taking care of humans. I think it's important for people to hear what he says, maybe read that book, because that's where opportunity is. It's inevitable. The question is, how do we position ourselves to be able to take advantage of the roles that we can play in this automation process? And in terms of radiology and pathology, the diagnostic fields of medicine, it's becoming readily apparent there's already software that takes care of a lot of the easy things. So the question is, how do we move into roles where we're capitalizing on that? And as radiation oncologists, we're very therapeutic. We're also very tech heavy, but we can see the way tools might change in the next 5 to 10 years to influence the way we practice. So I also mentioned Gary Kaplan. Gary Kaplan is the president and CEO of Virginia Mason University. Very well regarded for their lean processes. I mean, this hospital has been way ahead of its time in perceiving the need for a strong culture of automation, error-proofing, maintenance of quality measures and quality metrics for success. And basically they adopted the Toyota production system as their tool. So he said way back when that, Toyota's done a remarkable job of making sure that their front line, people who do the work, are most involved in correcting the work and improving inefficiencies and flow. So he adopted that method for his hospital, and in so doing really became the go-to place for where physicians who want to learn how to improve workflow, decrease waste, improve efficiencies would go to for tutelage. And then I put Paul Farmer. So Paul Farmer, I'm sure some of you are also aware of him. He's created Partners in Health. When he was at Harvard, he's from a lower middle income to poor family, but when he was at Harvard, his focus was really on understanding the global healthcare issues. He knew that he was able to provide the best evidence-based care in the United States, but he would go to Haiti, where they were just ravaged, without resources, under-resourced, without knowledge base, without training, and helped for years. So as his group Partners in Health grew, and they've now involved multiple countries around the world, his innovative approach and really disruptive approach to making sure that he could have the greatest impact by really spreading, disseminating current standards and current knowledge throughout the world made him a leader and makes him a leader today. So other radiation oncology leaders, radiation oncology specific leaders. Larry Marks, he's a chair at University of North Carolina. I find him disruptive for a couple of reasons. He's a strong proponent of quality and excellence within the hospital, and he showed his commitment over a decade ago by actually starting a division of healthcare quality within his department. So he was starting Lean before Lean was a thing for different hospitals. And by creating that division, he actually created a tour de force that the entire hospital and multi-site of UNC has now adopted and is implemented. And he's also controlled and helped them roll out a lot of their inefficiencies, because a lot of them had developed some Lean or quality setup, but hadn't really standardized the process in a way that the whole university can escalate, store their A3s, which is their changes for others to view. So it's very disruptive that a radiation oncology department would be the center of Lean, and of course, because of its success, other radiation oncology departments, prominent radiation oncology departments, go to UNC to look for that guidance. Wally Curran, the head of RTOG for years, disruptive in that he was the first, at least first that I know of, cancer center director in an academic institution, a ceiling that radiation oncologists really hadn't broken until about 6 years ago, and which in the context of the longevity of the field, right, the field has only been around since 50s, 60s, makes sense, but it's a coup for our field. So that he's disruptive in that way. Parker Griffith, again, the first that I know of head of a cancer center. He started Huntsville Cancer Center, I think back in the early 80s. With a very innovative approach where physicians were really tied to the institution but incentivized to really be leaders within the institution. And later he became the first congressman that I know of that was a radiation oncologist. So he was very prominent, very active in Congress, even as a freshman congressman, and was notable because he had switched parties in the middle of that in order to improve his power rank. But another disruptive leader. Mohan Santa, and I'm sure some of you might be familiar with him. He's the vice chair at University of Maryland. When Will Regine, his partner, became chairman, he's a very dynamic, very charming individual, and he'd been offered positions elsewhere, but chose to develop his career within the institution, moving along the dean's route, but maybe making a pivot to become more of a hospital leader about a decade ago. At that time, he got an MBA from Wharton. I think about 4 or 5 years later, he became president of St. Joseph's, an area hospital that was networked in the University of Maryland system, and then just last year became president of the entire University of Maryland medical system, which is a huge system and a huge position of prominence for a radiation oncologist. And then I put C. Norm Coleman here, who some of you might be aware of. He's at the NIH, was a Harvard professor and radiation oncology researcher, radiation biology researcher for many years. And he's been disruptive in just making sure he's played a prominent role in U.S. preparedness for disaster and advocacy in that range. So I've listed these people and kind of giving you historical context so you can understand where should you be looking for opportunities for growth. Well, to me, it's all about where are the areas of change. And right now, we're in a period of significant and rapid change. Only about 15% of physicians were employed in the early 70s and 80s. And even in the 90s, after there had been a push to try to make physicians employed, that employment rate again dropped to about 20%. But over the last 15 years, there's been a very intentional goal for hospitals and the government to make sure physicians move into an employed role. The advantages cited are integration of care, reducing the physician's burden on focus on the business, enhancing collaboration, transparency of patient information flow, etc., development of standard work within larger specialties, resource management and allocation by this more vertical integration setups, and allowing for career development for physicians along a leadership track that might not have been really available in a private practice setting. But there are disadvantages, and these are not often discussed, right? The primary source of physician burnout, regardless of study, is really loss of autonomy. We spend a lot of time learning what we learn in order to become the experts in the field, and to have people tell us how to do it, when to do it, and even to control how we get paid for it. It can be significantly dissatisfying. So loss of autonomy is big. And with this promised economies of scale with combining hospitals, we find actually that hospitals tend to run much less lean. There's much more administrative support and middle management that reduces the ability for the physician to really be more engaged in the process of managing the practice, thus sometimes increasing the wrong kinds of staff and increasing the complexity of delivery of care. As such, the cost of care has actually increased significantly with the with bringing physicians in, because even the reimbursement rates for physicians through hospital care versus private practice care is significantly different. The technical fees on the radiation oncology side, for example, are significantly more when you're able to negotiate through the hospital network rather than as an individual practice. And again, there's less flexibility, which ties into that loss of autonomy. So again, where's the opportunity? Well, it's where we need to change. It's about the problems that we're trying to solve. These are some things that I've identified as interesting to me, and unfortunately, as we'll go to later on, you can't do everything. But error proofing, boy, in the age of all this information and increasing patient contact and increasing revenue, RVU work, trying to make sure that we don't let things slip through the cracks is very important. So error proofing processes is a huge need in our field. Also, the automation of workload. There's multiple places that are trying multiple different ways of doing that, but being able to figure out how to more easily automate workload is important. Standardizing work, redistribution of workload, the ability to organize care, being actively involved in healthcare policy change, revision of labor costs, the geographic distribution of care, being able to impact how we deliver care, but also where, the globalization of care, and the development and sustainability of healthcare quality metrics. I think that that's actually extremely important in the context of all of this change, not forgetting why we're doing what we're doing and maintaining a certain level of quality. So these are our opportunities. So where do you start? So in terms of leadership, being entrepreneurial and innovation, I do think the most important thing is to really start with the improving yourself, really stepping outside of the hierarchical, rigid academic training that we've had to focus on personal development. And there's a lot of key literature that I found amazing in helping make this transition. Just the ideas of how to be more effective, what the real power of failure is, how to emphasize time, quality, be efficient, and how to really understand what you want out of life can really come from an autodidact approach of reading these key books. And I've listed some of my favorites here, and I've got a lot. I've read probably a book every 2 weeks over the last 3 years. But these are some of my favorites. For financial impact and understanding how people view you, the white coat investor is pretty important. once you become a physician, everybody wants to invest with you, for you, but not typically to your advantage. So having an understanding of what the basics are, spending some quality time understanding what your investment vehicles will be in life and where your money might be safer is important. And I think that his book, and at the time I actually started reading The White Coat Investor, it was a blog. He's just about the same age as I am, so it's been great to see that change. Rich Dad Poor Dad, actually I read it on the way to medical school. It makes you really, it's a short book with an amusing story and it's kind of a great sale by Robert Kiyosaki, really. But the idea that understanding what the cash flow quadrants are and what it means to be a high salary individual versus a high net, high passive income individual really helps you as you develop your financial plan for where you want to be in your life. 4-Hour Work Week, Tim Ferriss's book, outstanding book on how to manage your life. Though the title suggests a 4-hour work week, I think really what he's talking about is high effectiveness, high efficiency, kind of getting rid of the extra and the waste in your life. So again, continuous improvement and lean in your life first before trying to get it in your career. 7 Habits of Highly Effective People has been a treasure for years. I definitely recommend reading that and reading it probably more than once. The Power of Habit, an outstanding book on understanding why we do what we do and how to break some of those cycles and how maybe to strengthen others. Grit, The One Thing, and Success Principles. Again, Success Principles I find to be an outstanding organizational book, but we can always correspond. Hopefully after this webinar, you keep my contact information. But these are books that change the way I think and that have continued to impact me throughout my days. So, bottom line, how do I think when I look for opportunity? Well, Pareto's Law, everybody's heard about that, right? The pea plant experiment, where 20% of the pea plants produce over 80% of the 20% of the pea seeds produce over 80% of the plants. This has been shown in multiple different scenarios, right? 20% of the people control over 80% of the money. And whatever scenario you put into, there's always a smaller group of more disruptive, more productive people, depending on what the scenarios you're looking at. So, how to be one of those people? I think you have to really dial back into what we were talking about before. First, doing it practically is to really create for yourself a set of goals. As physicians, we're already type A, ambitious, we have got grit, and a lot of people just kind of get tired. By the time they complete residency, especially if they're not pursuing a particular kind of intentional career, you want to enjoy yourself. But part of that enjoyment really is seeking autonomy and having continued challenges. And a lot of people have faced that within 7 to 10 years of practice. They become real experts at doing what they're doing, and they're looking for the what next. So Success Principles book that I mentioned previously, they have a worksheet for helping you understand all the goals that you might have that are extraneous to what you're currently doing and helping you call those into a plan for your 3 to 5 year future, and I definitely recommend that. But the Warren Buffett actually has a separate test that's similar but more simple. Basically, he asks you to list all the things that you want to do to make your life great. And he says that list typically ends up being 30 to 40 things, or for some people less, some people more. But the idea is that you want to take the top 5 and then put the other 25 to 30 on the wall so you remember not to do them. The key to real success is really being able to focus in on your goals. When you start out the project, sometimes it takes a while to figure out what those 30 things, so spending a little time in self-exploration is fine, but at some point, relatively early within that process, you need to be able to cull the list so you can have life enjoyment and longevity, which is the real key to success. So, there's lots of different tools for leadership. Let's talk about actual practical ways to proceed. So I'm starting with leadership in quality because that's one of the areas that I've chosen to focus on. As you can see, there's lots of issues that we have in the healthcare environment. There's a lot of changes that were going to happen with macro next year, but man, meaningful use over the last 3 to 5 years has been a moving target, and it's all balanced and predicated upon maintaining quality. So as a physician, the easiest thing for us to stay involved in is making sure that we are part of the team creating the quality metrics so they're not made for us. And the truth is the institutions, societies, foundations are looking for people like us to help them do this type of benchmarking. And there's very few people that are actually trained. So I like this Money Management International photo. If it were up to people doing quality, quote unquote, rolling out quality that are on the financial side, the focus would be just low price. And our job is to maintain this high quality aspect to our care and focus on high quality first, but maybe having them focus on fair value or reasonable price. That's where we'll do our work, and that's where we can represent the best. So how do you do that? Well, there's lots of different ways to start. And I personally recommend starting with your institutional quality team. Every institution has to be involved with quality now that's providing care. It's just necessary for an inordinate number of accreditation bodies. And there's cores of hospitals, some very, very small, some very, very large, that devote time to making sure that they have an institutional quality team. But I would take it further. If you have an oncology quality service line team and a radiation oncology quality service line team, I would participate in that. And if you don't have one, I would start one. There's no better education than that. In terms of more formal training in lean, a lot of these places have difficulty rolling out the lean training to all of their employees, and physicians in particular have difficulty being able to sequester time in order to take a course. Here at OHSU, they actually have a week-long course for high-level managers and physicians, but it's been very difficult to get anybody but the top chairs involved. But when I volunteered and expressed interest, people were willing to throw me in and then throw me into positions of leadership immediately. So these are questions that you can definitely ask, and I guarantee there's people waiting to try to siphon away some of your energy, but also put you in a good place to be more successful. Outside of that, I believe it's important to have non-institutional learning. When you learn something from an institution, you can lose diversity of thought if you don't step outside the institution to get additional training. So one younger quality organization I like is the American College of Medical Quality. They've got a lot of well-known leaders, but it's still relatively small right now, and there's a lot of committees just recently being created. So it's an opportunity to get something called the Certificate of Medical Quality, which is basically they give you a couple big books that you read, you go over to the national annual meeting, you take the test, which certifies your medical quality, so you can use that designation CMQ, which means that you've done at least a little bit extra work. But more importantly, I think it sets you up in an organization that's probably going to really become much more prominent in the next few years because of the current members that are taking part in it. So I think you can take advantage of the scale and get in early. That would be a really good organization to join. The National Association for Healthcare Quality also puts a CPHQ, Certified Professional Healthcare Quality degree. This is a bigger institution and very, very well known among people in quality. A lot of big players. Most of the prominent institutions, Cleveland Clinic, Dana-Farber, Harvard itself, MD Anderson, they're leaders in quality for those institutions, have a CPHQ, and I found them to be great. Our advisor, one of the advisors I have, mentors, is from that organization. It's a relatively easy training approach, but again, by mixing that, merging it with what you currently have been studying, this could be a great way to advance. The Armstrong Institute for Patient Safety and Quality at Johns Hopkins, it was really more of a institutional safety quality initiative that built out, but now they run internal as well as external courses. You can get your Six Sigma Green Belt there, which is lean for corporate. That's the standard, and patient safety certificate course. Again, this can be done online, so these are very easy training modalities. One that I like for radiation oncologists is the ACRO quality training program. It engages you both with a team from your institution, or it does require you to go somewhere for 5 days over 6 months, so 2 days every 3 months, and then a final presentation. I'm in the midst of that right now. And they are now expanding the program to include an East and West Coast site. One of those sites will be here at OHSU, so one of the two sites nationally. the idea with this program is to create a team-based learning, so everybody is engaged as a group on the quality metrics. And again, it really does synergize well with the other types of quality learning I've had and gets you beyond the method to the meaning behind these initiatives. Sorry. So where does quality leadership, where does it lead, right? So I think it's important to begin with the goal in mind, but the goal in my case is not the leadership itself, but it's the process, it's the self-fulfillment, and it's the ability to preserve that sense of autonomy. I think that that's what makes us feel good in the end. But that said, I've met many people in these organizations now, and boy, the diversity of leadership roles that you have with just the pure quality leadership training has been amazing, astounding. VP of Medical Affairs, C-suite executives, all of them, CEOs, CQOs, CIOs, CTOs, and CFOs, and these are primarily quality trained physician executives. Managed care leadership roles, medical informatics leadership roles, boards, foundations, Medicare and Medicaid have quality committees that that high-ranking physicians have been on, and again, there's so few physicians that these are roles that you probably can easily aspire to. National Committee of Quality Assurance roles. So that's quality, and I've made a big plug for it because I think it's an easy foray, and the training and background are reasonable for you to kind of dip your toe in, but also not overcommit your time while you're learning the process. But I do think it impacts us greatly. So leadership programs. So what if you don't necessarily want to do this as a quality person, or you want to, in parallel, actually develop your individual leadership? Well, some of you might be in smaller practices, and you might already be in a position of clinical director or medical director, or more importantly, you might have a leader or a director that's not really as focused on the clinical enterprise. Well, you just got to fill that need. So it doesn't require very much training in order to be involved in the clinical workflow. People are literally dying to have physicians engaged in that process. So get a little bit of training. For me, I started with some core leadership training, so there's other books that I can mention for a reading list for this, but really the ones that I'd specified previously kind of give you a good entrance. But then I went for a leadership certificate program, and this is as slow or as fast as you want. The American Association for Physician Leadership has a certified physician executive program. It's about 150 hours worth of work. I know some physicians who do this 1 or 2 hours a month with a plan to maybe finish the 150 hours, over the course of 5 to 10 years, versus, knocking out the certificate over 6 months to a year. The key is that the literature is highly tuned for physician-specific leadership issues. And the association itself has a lot of alumni, though again, it's been around for years, but under different names. The alumni are often very prominent physician executives in their own rights. So if you ever see that designation CPE, it's because they're part of this organization and got that certification, but also it's a foray for you to ask more information and visit with them. I've gotten mentorship from several leaders with a CPE designation who were surprised that I was even aware of what it was. The other advantage of that CPE program is that it's kind of a bellwether for whether or not you might want to do an MBA. The CPE program, the APL, Association for Physician Leadership, they sponsor or are highly involved in several of the healthcare-specific MBAs programs that are around the country, Colorado, Massachusetts, there's several others, but they actually accept your 6 credits from that Certified Physician Executive Certificate course to kind of give you a jump start if you want to do an executive MBA as a physician. So it's one of those things where you can get a sense of what you need to know, really focus on the leadership development aspect of it early, and then complete an MBA, online or in person, and have jump-started the whole process. I think this is a very good approach. So in the interest of time, we're about 36 minutes past the hour. There's lots of other things that we can discuss, and hopefully I've brought up some things that will lead to some questions that we can discuss in the last 15, 20 minutes. But business, innovation, and entrepreneurship, this is a category that I think is extremely important, and I don't know about the backgrounds of everybody that's listening, but a lot of people become physicians because they're hardworking and have a lot of grit, a lot of ambition, want to do a lot. Getting the financial portion of the, getting the wealth and the sustainable growth and income as part of it can confuse where you believe true success to lie. So I've always believed that it would be great if you could separate those two. And part of separating those two actually is maybe to build off on things that are of interest to you, to take innovative solutions to educational problems, to business or workflow problems, and create a way of processing and automating them in a way that it can turn into a tangible side business effort would solve two problems, right? It makes the job that you choose the job that you choose, not the job that you're forced to have. And that's important. Creating independent businesses outside the institution. Right now I've got 7 LLCs, and my mentor probably had 12 or 14. It makes the job less important. Sorry, for your money and sustainability, but then for your enjoyment. So I'd highly suggest that you participate in innovative endeavors. A lot of companies are out there in this space, in radiology, radiation oncology, interested in touting their software or educational changes in the field. They're looking for physician partners. Physicians create kind of legitimacy of the process. You have to take care in how you get involved in the process, and I prefer personally not to take equity positions or get paid for a lot of the work that I do. I like a lot of stuff to be on an advisory role only at this stage of my career because I don't want to be too mired in the business aspect as they start up. But the key is later on it could turn dividends not just in your educational process of learning how businesses run, how ideas are brought to market, but in creating business relationships that could really benefit you later on in life in advisory positions on boards. So something to definitely think about. So finally, there's thought leadership, and one of the reasons I came to OHSU is because the mentorship of Charles Thomas here, who's known to many in the field as a great mentor, and you know, spending time with him here, it's incredible the amount of energy and time he spends in making sure people that he's touched, as he likes to say, touched, felt, smelled, do well, and that he's engaged in their lifelong process of improvement. Part of that is understanding where do you want to stake your claim in your niche as an expert. We all, again, are smart. We can all take a small area within the field and really be an expert. Dr. Tim Minton here has been focused on bladder preservation as a satellite physician and has done talks over the whole world, education lectures in Russia, been on major panels, ABR examiner as a satellite physician. Everything is doable if you control the scope and maintain the focus of what you want to do. So I think thought leadership is just as important, if not more important, than all these other things. Take out an area that you want to be a true expert in and make that the goal, and leadership will come. So first steps, identify mentors that you wish to emulate. There's a ton out there. I mentioned a bunch in those the first session just to show you how different the types of leaders are in our field that are already in the field of radiation oncology that you can reach out to. I've reached out to people like them, Joe Simone, editor of Primary Oncology Times, who's been a leader at St. Jude's and MD Anderson, etc. Reach out to people that you want to emulate. They'll be happy to have you speak to them. I was surprised that Joe wanted to know and be engaged in every step of my path over the last 4 or 5 years. Even when I was trying to decide where my career was going to take me, he wanted just to have that follow-up. I created a 1, 3, and 5-year plan. Make it detailed, even though you know you might pivot at any time. Make your reading list and read your first transformative books. When you start talking about the last book you read, then you know you're on a different path of self-improvement than just focusing on your clinical practice. Focus on yourself. Identify those top 5 goals. Determine your financial strategy that would separate you from the need for your job. And split out financial goals from your career goals effectively. So we're at that time, James.
All right, everyone. If you have any questions, you can open the chat menu at the bottom and submit questions to staff. So if you look at the drop-down and click Send Questions to Staff, any questions you send can be read by me to Dr. Jaboin. So we'll give you a minute or so to submit questions. So I actually have a question. How would you go about finding a mentor? Let's say you have a particular area of interest that isn't really satisfied at your current practice or at your current school. What would your steps be to go about finding a mentor to meet?
So I think actually one of the greatest resources is actually ACRO, because it's full of a wide variety of practitioners that do a wide variety of things. Approaching the president of the organization or one of the ACRO committee members for advice would be a great way to go. I'm always available personally to find and locate someone that you might want to work with, and I know that others would do the same. So I'd start with your national society, because that's your pipeline into a whole group of people, and you never know what other people are doing if you don't reach out.
And I guess what would you say to someone who's considering going between either an academic practice, setting up shop in their own freestanding clinic, or going to a community hospital? How would you recommend they go about talking to someone with more experience in that area?
Oh, no problem. So I'm very concerned with someone trying to set up independent practice at this time. With the change in political winds, I don't know exactly where things are going to go in the next 3 to 4 years. But the way things are firmly going was if you're not within a network that has a strong referral base, so either a very large practice group that's multidisciplinary, I think it's very difficult, unless you're in a very rural setting, again, I could use a lot of areas here, to know that you'll survive. So I'd be very cautious about taking a 2-3 year partnership stake in something that might not exist by the end of those 2 or 3 years. In the case of hospital-based employment and academic positions, I definitely recommend utilizing the resources of, I'm plugging ACRO, but really ACRO, ASTRO, or just some person who has a lot of experience. I've read a lot of contracts, and there's a lot of funny verbiage of of how people pin salary scales and complicated financial models. In the end, you will be happy only if a multitude of your needs are met. A basic sense that you're being rewarded financially for what you do, and a basic sense that you have a stake in the future of your practice. Those are my two go-to things. If one of those two aren't satisfied, the chance of you moving to the next job in 3 to 5 years is very, very high. So I would definitely talk. I think there's a tendency for people not want to talk about their money and their jobs. I would talk to someone who's been through it, someone you can trust. I love talking about those things, so you can always reach out to me. And I'm happy to go through a contract with you. And I would actually recommend spending money on having a lawyer who's familiar with our field do it too. And they're all over the place. I've hired 2 myself to go over contracts, and you'll get a sense for what they think is absolutely ridiculous, and you will not hurt the feelings of the people that you join, because it's just business. You let your lawyer be the bad guy or girl.
And last question for me. How would you recommend radiation oncologists coordinate with the administrators or the medical physicists in a practice? Have you come across any um, issues working between the two different teams since they have different levels of training or different types of training?
Yeah, definitely. That's actually an area that I think we need to focus on, and that we could have a good long talk about that. But uh, essentially, every place there's multiple models for physics employment in particular. So I'll start with physics. Physicists have been employed in a department underneath a chairman, which chair could be a physicist or administrator or whatever. Um, they've been employed where they're an equal partner to an administrative director and a physician. And we've seen them completely be employees of the hospital and disengaged from the clinical practice or being touched, quote unquote, by the physician group. I think the model that best and most effectively delivers care is in a partnership model. I think like-kind professionals should manage each other. So I think that the ACRO's their guidelines from 2012 about patient safety really emphasize the fact that the physician-physicist should be a team. And what the newer models for clinical development, so there's a lot of stuff that's buzzing around, but the idea of a physician administrative dyad, or single point of leadership where all three people are basically at the same level, I think that's where we're going. So I think that people might be fighting against that machine, but the best way for us to work and create seamless workflow is to work closely together. So I'm not sure if I got to did I get to the crux of your question,
Yeah, that helped.
James?
Thank you.
Yeah.
And that looks like all the questions we have. So thank you very much for your time, and thank you everyone for joining us today.
Oh, thank you. Thanks for inviting me.
And in case anyone was wondering, the ACRO meeting you referenced is going to be March 9th to the 11th, 2017 in Orlando, Florida. And you can find all the information on our meeting at acro.org. Thank you very much.
Thank you.
Have a great day.
Hey, take care now.